So my focus will be towards talking about the day-to-day issues and then to decide what we really need. So what are the major issues when you want to set up a diabetes clinic? See, if a physician has to primarily manage diabetes, then say goes into the area of diabetes clinic. If you are going to manage multiple issues and diabetes becomes a part of that management, then it may be a different story. And this is what I believe is the major issue when we want to set up a diabetes clinic or work like a diabetologist. One is information patient can provide us is huge. He has a lot of information. He has a 10-year experience of diabetes. You can spend 1 hour easily with this fellow. Now we have to manage in a manner that we have to convert this huge data into a small piece of useful information. Because otherwise we can take a decision in 10 seconds what we have to do, that we are aware, but these all areas are very time consuming, and in setting up the clinic we have to find out the modalities by which we can modify this to this. And this is an area where patient may not come with complaints. You will have to search what problem this patient has from inside. Does he have a retinopathy? Does he have a nephropathy? He is not symptomatic. Does he has a dyslipidemia? So it becomes physician's job rather than the patient's aspect, because in other disciplines they will give some complaints and you have clues to a diagnosis. And then this is an area where prescription alone doesn't work. There are so many issues which our patient want to discuss. Training of patient is not on just one aspect. There are multiple areas: prescription, insulin, self-monitoring, diet, lifestyle, hypoglycemia. So many areas our patient want to discuss. And since it is a chronic lifetime disease, okay, we all want electronic database and do all these things, but be very clear that what you had prescribed and what patient is taking today may not match. Because this is a disease where they are trying all indigenous medication, that doctor, this goes on. So this is again a big challenge to have a verification on the previous treatment. Then these are big issues: myths, discussion time, many patients asking treatment on phone without coming to you, comorbidity management, and then any patient who has any problem, a dental pain is due to diabetes, osteoarthritis is due to diabetes, everything patient has is due to diabetes. Because the next doctor will always tell him, you should talk to your diabetologist, your sugar is high and probably this knee pain seems to be connected with diabetes. And at the end it is the diabetes doctor who has to handle all these things. So non-diabetes complaint handling, these are big time consuming areas. And we sometimes create difficulty in how to manage such patient. So diet and lifestyle issues. If you start this topic with a patient, he may take next 10 to 15 minutes. If you start, are you following the diet regularly? Are you consuming? Okay, listen doctor, I wake up in the morning at this time and then this is my schedule. Now he has full interest to deliver all this information to you. But what at your end? You are from inside boiling. When this fellow will stop? So this is a really big issue. Whenever you talk of insulin, initiating insulin therapy, a big time consuming area. Self-monitoring of plasma glucose, we have to finally, ultimately, you ask a patient to do these tests, everything is done, patient comes with that detailed workup and doctor doesn't even have time to look at that. He feels highly disappointed that no discussion was done on this hard work. And then sometimes what therapy you had prescribed and what SMPG you were actually needing, there is no match. So these are all areas which require a lot of discussion with the patient. Hypoglycemia management. You started without 2 shots and you want to move to the basal bolus. Intensification issue. This microangiopathy complication management issues. So what we need when we set up a diabetes clinic? Now depend at what volume you are working, the way you want to work. You are in a hospital setting, a small clinic, a team clinic, depends. But you need to have a system to collect the information from patient and organize. That you may do yourself also or your assistants can do it. So whenever you plan to set up a diabetes clinic, keep a space for this area. Then we have to plan some need-based education. Okay, this particular patient requires this education, modulate something so that receive that education. Diet, this here I do a lot of work because at most of the country in India there is no connection between the diet planning and treatment planning. Treatment is going in one direction and dietitian is planning a standard care. Suppose you have prescribed a patient a 50-50 insulin with certain plans of diet, and now dietitian suddenly changes everything to a standard care set. Okay, morning 6 o'clock this, 8 o'clock this, 11 o'clock this. Our all therapeutic regimen failed. So we have to have some communication with our dietitian, nutritionist, so that they can follow what we want. Myth removal, this is a big area. Keep on discussing. You may not remove it forever in most of the patients or many patients, but still we have to keep on trying this area. In spite of our all education, communication, they are going to indulge into various kind of solutions for diabetes. But anyway, this is the area we have to keep on. Then prescription explanation, insulin, self-monitoring, hypoglycemia training. So whenever you set up a clinic, we will have to provide adequate space so that we can place adequate manpower who can take care of all these issues, so that we have to focus mainly on the treatment related issues. So we need a trend team. Create as per your need, but at least have 3-4 persons working with you. If you have this much staff of 3-4 persons minimum, then there is no upper limit. Depending on the number of staff you have, we should have at least 700 square feet space, because we need a small laboratory. We need certain area for education person, some area for assistants, so that they can prepare everything for us. Record keeping will be a good advice, because it will save you a lot of time when patient comes back. It may be a hard copy system, it may be computer, it may be both, whatever you want. You can use different education modalities, including 1:1 education. You can create certain videos, you can create a video room kind of thing. We follow all modalities, we follow customized education, we follow certain, we have prepared videos which patients can see when a specific issue is there. They are very specific, point oriented. And then we can have a scripted method. Because don't just believe that, okay, this is an educator and going to do all things right. No. So what we do, I provide them a ready-made script that, okay, I want you should say this particular thing to this patient. That's it. Don't go beyond this. Because sometimes they may cross their borders and patient can get rather more confused. And then we can have certain softwares which can make our OPD system quite easy. At our center, we are using all these technologies to make it as smooth as possible. Time management is really a big challenge, and most of the Indian doctors are not utilizing technology in their clinical work. We are trying to do each and small work by our own, and most of the time wasting time into that area. One reason is most of the software is being developed in a manner that they may not be very physician friendly, so we need technology which can make our work easy. So this is what just a glimpse, and now we can have a discussion. Dr. Gupta, please.